All right, welcome to the Deep Dive. Today we are cracking open a diagnosis that sounds super technical, but it's really a major evolving frontier in medicine. We're talking about cardiomyopathy or CM.
Yeah, and at its core, it's really just a disease of the heart muscle itself.
Right, it's a primary disease of the myocardium.
Exactly. That's the critical starting point. Now, you'll often hear clinicians talk about things like ischemic cardiomyopathy or hypertensive cardiomyopathy,
Sure.
but those are actually secondary. They're caused by something else, like clogged arteries or really high blood pressure.
So today we're sticking to the primary CMs.
Yeah.
Our mission is to first kind of simplify that traditional classification system, the three main types based on how the heart looks.
The morphological types, yep.
And then, and this is the really cool part, track how fast that whole system is being overturned. We're moving away from just what the heart looks like.
And moving toward what caused it. Sometimes right down to a single gene. It's a classification system that's really in motion. But for decades, it's all been about the big three phenotypes.
Okay, let's start there then. Let's do the one that feels the most intuitive. Hypertrophic cardiomyopathy, HCM.
Right.
This is where the heart muscle just gets too thick, right?
Precisely. HCM is all about increased left ventricular, or LV, wall thickness. For a diagnosis, we're usually looking for a septal thickness of 15 millimeters or more in men,
Okay.
and 13 millimeters or more in women. But here's a little nuance.
Hmm.
If you're a relative of someone with known HCM or you have a positive genetic test, even 13 to 14 millimeters can be enough for a diagnosis.
So it's not just a bigger muscle like you'd get from working out. It's an unhealthy, thick muscle. What does that actually do to the heart's function?
Well, it creates a huge problem with compliance. The ventricle walls are so thick and stiff, they can't really relax and fill properly.
Ah, so it's a filling problem.
It's a filling problem. The pressure inside just skyrockets.
Yeah.
But, and this is crucial, the pumping strength, the ejection fraction, or LVEF, is usually normal. Sometimes it's even really high, like over 60%.
So squeezing blood out is fine. It's getting the blood in that's the challenge.
You've got it. And the thickening isn't always neat and tidy, which can make imaging tricky.
How so?
Because the pattern of hypertrophy is just so diverse. You can get the classic asymmetric type, where the wall between the ventricles is thickest.
Okay.
Or you might see it concentric, where the whole chamber is evenly thickened.
Yeah.
Or even just at the tip of the heart, the apex, which can be really easy to miss on a standard echo.
This sounds like a diagnostic minefield. I mean, athletes have thick hearts. People with high blood pressure get thick hearts. How do you tell the difference?
That is the big aha moment for a cardiologist. You have to be systematic. First, rule out the athlete's heart. That's benign.
Right.
Second, rule out severe chronic hypertension or a tight aortic valve. And third, and this is critical, especially in older patients, you have to rule out cardiac amyloidosis.
What's that?
It's a disease where protein deposits in the heart muscle, and it can look exactly like the asymmetric thickening you see in HCM. You're looking for the cause, not just the shape.
Okay, let's flip to the structural opposite then. Dilated cardiomyopathy, or DCM. So if HCM is too small and stiff.
DCM is too big and floppy. That's the classic way to think about it. The left ventricle is enlarged, it's ballooned out, the muscle is stretched thin, and it's just not an efficient pump.
And what are the criteria there?
Initially, we look for an LVEF of 50% or less, and you also have to have that enlargement, which we measure a few different ways.
Let's pause on that LVEF number because I know those thresholds are really important for treatment decisions.
They are absolutely vital. An LVEF of 40% or less, that's your trigger for starting all the core heart failure medications.
The ones that are proven to save lives.
Exactly. But if that number keeps falling down to, say, 30 or 35%, that's when we start to seriously talk about a primary prevention ICD.
An implantable cardioverter defibrillator.
Right. Because at that point, the risk of a life-threatening arrhythmia, of sudden cardiac death, it just gets too high.
The sources also mention this idea of a mid-range LVEF, somewhere between 40 and 50%, as being this transition zone for DCM.
It really is. It's a fork in the road. It could mean the patient is deteriorating, getting worse, or hopefully it means they're getting better.
Better.
Yeah, it could be a sign of reverse remodeling. It means the therapy is working, the ventricle is shrinking, the muscle's getting stronger, and they're heading into remission. It's a really dynamic number.
Got it. Okay, so on to our last traditional type. Restrictive cardiomyopathy, RCM. This one's the rarest, right?
It is, and RCM is a bit different. It's less about a specific look and more of a severe functional problem.
How do you mean?
It's diagnosed based on really bad diastolic dysfunction, that same filling problem we talked about with HCM, and very high filling pressures inside the heart. The walls might look normal or thick, and the pump function, the LVEF, is often only a little bit reduced.
So if the pump is mostly okay, why do patients get so sick?
Because the pressures are just incredibly high. That pressure backs up into the whole system. You see massive enlargement of the atria, the top chambers, and clinically, it's often right-sided heart failure that dominates.
So like swollen legs, fluid in the abdomen, that kind of thing.
Exactly, even though the problem is in both ventricles. And here's a big clue. If you see a restrictive pattern with really thick walls,
You're thinking of a specific cause.
you're immediately thinking of infiltrative diseases, things like amyloidosis again, or certain inherited metabolic diseases. The structure gives you a direct clue to the etiology.
Okay, so let's get to the really revolutionary part of this. The sources are so clear that these three boxes, HCM, DCM, RCM, they're just not static. The lines blur. Hearts change over time.
That is the central challenge in cardiology today. Morphology is just where you start. Take HCM, for instance. In about 5% of patients, that stiff, thick heart eventually burns out.
Burns out.
Yeah, the muscle thins out, the ventricle dilates, and the ejection fraction drops. They effectively evolve from an HCM picture into something that looks more restrictive or even dilated. The definition just doesn't hold.
And we already mentioned DCM can get better with reverse remodeling. This sort of fluidity, it led to the need for a fourth category, right?
Yep.
Arrhythmogenic cardiomyopathy, ACM.
Exactly. ACM is this fascinating and frankly terrifying entity. It's defined by its electrical instability, and it's mainly driven by genetics.
It used to be called ARVC for the right ventricle.
It did, but now we know it can affect the left ventricle too, so we
Ah.
call it ACM-LV. And structurally, it can look like DCM, maybe even a bit like RCM, but the clinical difference is it's huge.
And this is a really key insight, isn't it? Because in normal DCM, you said we wait for the pump function to get down to 35% before thinking about an ICD.
Right, but with ACM-LV, patients have these life-threatening ventricular arrhythmias before the pump gets that weak.
Wait, hold on. So the LVEF could be, what, 40, 45%? And you're
Right.
still thinking about a primary prevention ICD?
Absolutely, because the risk isn't from the pump weakness. The underlying disease is different.
How so?
In ACM, healthy heart muscle gets replaced by fat and scar tissue, and these patches of scar create electrical short circuits. So the risk of sudden electrical failure is way out of proportion to the mechanical weakness.
So the etiology, the cause, completely changes the treatment plan.
It overrides the morphology. It's a perfect example. A confirmed genetic diagnosis of ACM means you have to think about an ICD much, much earlier.
And it's not always genetic, is it?
No, absolutely not.
No.
Acquired diseases like sarcoidosis, which is an inflammatory condition, or an infection like Chagas disease, they can create the exact same scar and arrhythmia landscape. They create an ACM phenotype.
Wow. Okay, there's one more thing that complicates this classification. Left ventricular non-compaction, or LVNC. It's like a spongy-looking heart muscle.
It is. It's very striking on imaging. We have a specific ratio we look for, the non-compacted to compacted muscle layer. But LVNC is maybe the best example of why just looking at morphology is failing us.
Why do you say that?
Because it's so variable. You can see it in severe HCM or DCM, sure, but you also see it in perfectly healthy hearts. It can show up during pregnancy and then go away. And it's much more common in elite athletes.
So if you just classify it as a disease based on its shape, you're going to overdiagnose a lot of people.
A lot of people. Which brings us to the big conclusion here. The field is moving past phenotype and heading straight for etiology. And a big part of that is the two-hit model.
Explain that. What's the two-hit model?
It's a way to understand why one person in a family with a bad gene gets really sick and their sibling with the exact same gene is fine.
Okay.
The first hit is the genetic predisposition, the faulty gene. The second hit is some kind of acquired trigger. It could be a bad viral infection, high blood pressure, toxic exposure, even just the stress of pregnancy.
So the gene loads the gun, but the environment pulls the trigger.
Beautifully put. Which leads us to the practical side. A patient comes in with symptoms. How do you start this search for the actual cause?
The etiological search.
Right. And first, you have to separate the syndrome from the diagnosis. The syndrome is what the patient feels. They're breathless. They're tired. We used to just call that congestive heart failure.
But that's just the symptom.
It's just the symptom. The diagnosis is finding out why. Is it HCM, DCM, amyloidosis? What is it?
So step one in that search.
Clinical history. You have to be a detective. You do a deep dive on the family history. Any heart failure, muscle problems, any sudden death. You hunt for toxins, alcohol, chemo, radiation. You really assess their activity tolerance.
And then you move to imaging.
Then imaging. The echocardiogram is still the workhorse. It gives you the basic shape and function. But the real game changer now is cardiac MRI.
Because MRI sees more than just the structure. It can actually characterize the tissue itself. What are you looking for?
We're looking for injury, inflammation, and scar. We use a contrast agent for something called late gadolinium enhancement, LGE. It literally lights up areas of scar tissue, old, permanent injury. But even newer are techniques called T1 and T2 mapping. T1 mapping can see diffuse fibrosis, scar that spread all through the muscle. And T2 mapping measures water content, which is a huge sign of active inflammation or edema.
So if you think someone has myocarditis, active inflammation.
T2 mapping is indispensable. It tells you there's active disease that might need immediate anti-inflammatory therapy. We're moving from a macro view to a micro view.
And the lab work must be just as broad.
It's a huge fishing expedition because so many systemic diseases can hit the heart. You run the standard stuff, electrolytes, kidney, liver, thyroid, but then you do targeted searches too. Iron studies for hemochromatosis, eosinophil counts, muscle enzymes.
And then if all that initial screening points you in a specific direction, you do the real deep dive tests.
That's right. That's when you bring out the big guns. Genetic counseling and testing with these big multi-gene panels. Specific infectious disease testing for Chagas's, Lyme, HIV, and sometimes an endomyocardial biopsy where you actually take a tiny piece of the heart muscle.
You don't do that often, though.
Only when finding a specific diagnosis will immediately change your therapy, like confirming amyloidosis or giant cell myocarditis.
And where does a coronary angiogram fit in?
That's for when you suspect that blocked arteries, ischemic disease might be contributing, and you think you might be able to go in and open them up.
This has really painted a clear picture. We are watching a true paradigm shift. We're moving away from defining these diseases by how they look. Dilated, hypertrophic, restrictive.
And we're moving toward defining them by their root cause, the specific etiology. Genetic, infectious, infiltrative.